Welcome, everyone, and thank you for joining us here in Washington, D.C. and from around the world online to discuss how addressing stigma and gender inequities can help strengthen HIV and AIDS programming and policies. My name is Julie Pullerwitz, and I'm the director of the Population Council's HIV and AIDS program. As many of you know, the Population Council is a global research organization working in more than 50 countries worldwide. We conduct social science and biomedical research to improve programs and policies and develop innovative technologies that address critical health and development issues, including HIV. Over the past 20 years, the Population Council has generated evidence around the magnitude and effects of HIV stigma and has designed and tested strategies aimed at reducing stigma and improving HIV outcomes. For example, in the early 2000s, the Population Council embarked on the first large-scale effort to document the HIV-related vulnerabilities of and discrimination experienced by men who have sex with men in key countries in sub-Saharan Africa, a group previously unrecognized by the public health system. Since then, the Population Council has continued an extensive body of HIV research and program work with a variety of particularly vulnerable populations, including sex workers, people who inject drugs, and adolescent girls. You'll hear a little more about this work today, including findings from Project SOAR, our USAID-supported global consortium that is conducting almost 60 HIV and AIDS implementation science studies around the world. But why address gender and stigma now? Through our research and the experiences of many here in the room, we know that stigma continues to be a persistent barrier to HIV services and program success. And the experience of stigma is particularly highlighted and heightened amongst vulnerable and criminalized populations. Assumptions made by many that when HIV drugs became widely available, stigma would disappear have not turned out to be the case. Today, we want to highlight how HIV stigma is often exacerbated by gender inequities, which leads to multiple and intersecting stigmas, such as homophobia and stigma related to adolescent sexuality. And that tackling stigma successfully will require addressing gender as well. And as you will hear from many of our great speakers and panelists today, without an evolving HIV response that directly confronts stigma and the gendered aspects of stigma, global goals to expand access to care and treatment will not be achieved. There is an urgent need to generate and share evidence to combat gendered stigma, ensure that policies are grounded in science, and to scale up proven stigma reduction interventions. And this is one of the reasons we are so delighted to be here today, together with diverse researchers, programmers, advocates, and donors who are together committed to addressing this issue. Now, let me introduce our keynote speaker, Dr. Chris Beyer, Desmond M. Tutu Professor of Public Health and Human Rights at the Johns Hopkins Bloomberg School of Public Health. Dr. Beyer is globally renowned for his work in this field and as the recent president of the International AIDS Society, and likely needs no additional introduction, but let me add that he serves as director of Johns Hopkins training program for HIV epidemiology and prevention science and is the associate director of the Johns Hopkins Center for AIDS Research, their CFAR. Please join me in giving a warm welcome to Chris Beyer.
Well, thanks so much, Julie. Good morning, everybody. It's wonderful to be here. It's particularly wonderful to be here because we've had the good fortune to collaborate together now for a number of years on Project SOAR, Chapigo, Kelly Curran, Julie Perlowitz's group, and our Hopkins team. And it really has been it's been a very rewarding research and I think important research collaboration. So, and of course we are very grateful to our donors who've been funding this, USAID. So my task was to talk a bit about this issue of gender and HIV stigma, the complexity of it. And what I thought I would do is talk a little bit about kind of what we see in the field, what we know is happening now, and then lay out maybe just a few kind of new advances in the field that may have an impact on stigma. I want to just start by saying a couple of things as kind of key messages at the beginning, but hopefully these are the take-homes as well. And the first, as Julie noted, and it really is the case, we've all been struck by the stubborn persistence of stigma. We thought treatment was going to change it. There have been an array of campaigns and efforts, but as the epidemic and our responses to it have progressed and changed, you find that stigma recurs and continues to be a challenge. So, for example, we're starting to see the HIV and the other kinds of intersectional stigmas around gender, around sexual and gender minority issues, having impacts on PrEP. Just as an example, I have an R01, an NIH-funded study with male sex workers in Bangkok, and every single adverse event that we have had to report to our ethics committee has been an issue around stigma associated with PrEP, and a kind of conflation and confusion around that as people thinking that it's HIV meds and aiming, again, stigma of HIV at people who are actually uninfected and trying to do better at preventing HIV infection. So and this is, I think, going to play out as we get more advances, that they too are going to face these same issues. So we really have to take this one on. Enacted stigma in the form of discrimination and legal sanction continues to be a very big problem in this country and many others. I want to talk about that a little bit because our group has been very involved in trying to address that. And lastly, I would just say, and Project SOAR has been a part of this, and many others in the room's work has been a part of this, that there really are advances both in the social sciences and in the interaction of our new biomedical interventions in social science that really, hopefully, are going to provide some ways forward to address this and to combat it. We just recently had the Center for AIDS Research a directors meeting. This was hosted by Emory in Atlanta. Cornelius was there. And our new CDC director, appointed by President Trump, gave a talk. And this was the theme of his talk. This is a direct quote from him. I told him I was going to quote him, and I am. Stigma is the enemy of public health. Yeah, it is promising, indeed. Yeah. Now, I think, there's admirable clarity about where we are scientifically right now. That has not always been the case. So I happen to love this from WHO, the new guidelines. It's really just two things. So treatment for everybody living with the virus and the consideration of antiviral-based prevention for people at high risk. And we now know, and we have very good evidence from a number of places, won't have time to get into that today, but it is certainly the case that if you can do both of those things, you really do see declines in new infections, declines in mortality, increases in life expectancy. It is remarkable. And this is really pretty simple. It's until you actually try and do it, as our PEPFAR colleagues well know. But so, why can't we? And I think you have to say that part of the answer is the persistence of stigma. Right? It is an absolute barrier to what we need to achieve. So, of course, the persistence of gender disparity and gender inequality is at the core of this. And in some ways, the stigma around particularly young adolescent girls and young women's sexuality is arguably at the very core of why we're doing so badly. And I think you really only have to look. This is actually a slide from Linda Gale Becker, colleague and friend. Looking at where you are with, this is up to age 21, the gender disparities in the most affected region of the world, as we all know, Eastern and Southern Africa, are just breathtaking, and they continue, right? And all the advances that we've had have not actually budged this very much, right? And that is also profoundly related to the unmet need for contraception. So I thought it is worth saying that the questions around sexuality and reproduction, which are at the core of heterosexual transmission of HIV, also relate profoundly to family planning challenges, right? And again, that also has to do with some of the issues around young women and girls that we most want to protect, right? We know, and this happens repeatedly, that there is real concern at the provider level, at the clinic level, for sexually active women and girls who don't have husbands and are not married. Right? Actually get turned away from family planning, get turned away from PrEP, and those are precisely the people who need contraception and arguably need PrEP. Right? And that is a persistent intersectional stigma that we face in so many places. I just want to talk a little bit. This is just one infographic. Some of you may know that this summer at the International AIDS Conference in Amsterdam, we released a Lancet Commission report on global health and HIV and trying to look at integration of services and looking at ways forward. And one of those areas of integration was to try and think about and address this issue of HIV services, in particular PMTCT, prevention of mother-to-child transmission, and unmet need for family planning. So we thought we should take the country that actually has the biggest problem with perinatal transmission, that is Nigeria. Nigeria sadly accounts for more than 30% of all infected births worldwide, that one country, right? So that really matters. It turns out that the model that the country is using and that UNAIDS uses then to report and that the Global Fund funds for Nigeria are based upon is the spectrum model. It's a development of the goals model. Many of you know that. Here's a question for you. True or false? The spectrum model allows you to include contraception in assessments of HIV services for women. False. Right? Which is something you think about in 2018. It's kind of breathtaking, right? Here you are, and you have this goal of trying to reduce perinatal transmission, and you can't even assess the impact of contraception. Because, by the way, family planning and effective contraception is HIV prevention for women and girls, right? That is one of the ways that you avoid transmission is you avoid unwanted pregnancy, right? Particularly for infected women. So we decided to do that, to try and build a model. We had some very smart people. We're going to talk about that this afternoon at CSIS. That was not a plug, but kind of was. And when we did that, very quickly, first of all, it's an enormous challenge to do, but when you do it, what you see very quickly is that by integrating family planning and addressing the unmet need for contraception among women in this country, you could reduce by over half new HIV infections in infants. So you have a big impact on perinatal transmission, and you could avert 8 million unwanted pregnancies. So that's an example of something that is kind of a no-brainer. You think, yes, that makes perfect sense. We should really do that. But you have to accept that you are expanding contraceptive access, and you are expanding it for women who are not married as well, right? And for young women. Now, of course, we are facing, as everybody knows, a new challenge in this domain. This is, unfortunately, I think, a good example of enacted stigma, which is the expansion of the Mexico City language to the PEPFAR program, which actually increases limitations on contraceptive access by an order of magnitude, right? This was always there for USAID, that's $500 million a year, PEPFAR at over $5 billion. It's an order of magnitude more severe. So that's going, obviously, in the wrong direction of enacted stigma. But of course, gendered stigma also affects men in a big way, right? So we have looked at this carefully over the years. We did a meta-analysis some years ago of the persistent higher AIDS mortality in men, which, by the way, is the case across sub-Saharan Africa, and it's also the case across Asia, South and East Asia. And these are just data that basically describe the issues that relate to men, which many of you know, which is that they're less likely to get tested than women, they're less likely to get tested early in infection, they present later, and they have higher AIDS mortality at 1 year post-diagnosis, and it persists. They have higher AIDS mortality 5 years after diagnosis. And that is a gendered issue that is a really challenging one. There's a new RFA out, as people may know, about doing better, engaging men in care. But this is a complex aspect of men and maleness in many of these settings that has deep gender roots, right? Men are strong and healthy. We don't seek care until we can't work. That usually means, in the context of HIV, still we're at something like, what is the median in PEPFAR? 270 CD4s or something at diagnosis, and it has not budged very much in decades. So that remains an issue. And then, of course, there is the stigma associated with key populations. So this is from a wonderful talk, if you haven't seen it. Steph Barral, who's a colleague in my group at Hopkins, did a plenary on the epidemiology and key populations for Amsterdam this summer. And this is a map of where there is data on stigma, regular stigma measures being collected on key populations. Kind of spotty. That's the take-home, right? And it does not exactly capture the parts of the world that we are most concerned about, right? So obviously, as you all know, the majority of people living with HIV live in sub-Saharan Africa, and it's essentially almost blank. And one of the points that Steph made, which I think is really important, this is also from his plenary, when we think about stigma, is that we often parse the world and think about developing countries and the West, the global South, the global North. What these are measures of the experience of stigma and discrimination among men who have sex with men. And it's from the American Men's Internet Survey. That's the green color, and then 2 African countries. And I'm sure none of you can see that. I'll have to step off the stage to remind myself what these are. Yeah. Police refusal to protect. Scared to be in. Yeah. And physically hurt. So, what you're seeing here and what the take-home here is, and by the way, some of those, like verbally harassed, are worse in the U.S. Than they are in sub-Saharan Africa. The world, unfortunately, for LGBT people, and in terms of these stigmas, looks more the same than it does different, unfortunately, and it shows you, in a way, both the persistence of stigma and the pervasiveness of it. So, what about some ways forward? I've thoroughly depressed you all, and so I'm just going to lay out a couple of things that I think either are with us or on the horizon that myself and others have thought may really help us deal with this issue. So the first, of course, is that we have a lot of testing innovations, and particularly self-testing, that allow people to get out of stigmatizing clinic kinds of settings and environments, and to take ownership of learning their HIV status. So we, for example, are doing this with AMFAR support in Myanmar with LGBT populations, and seeing an impressive, happy, higher uptake of willingness to get tested and better connectivity to care. With self-testing. There's great data from Malawi. This is actually summarizing data that was presented at the IAS this summer. So self-testing is an innovation that may help us overcome some of this. And then there is the whole movement around U equals U. Right? Undetectable equals untransmissible. And the idea that the science now really supports that people who are effectively and sustainably virally suppressed are not infectious for their sex partners. And we think and hope that that is going to be an empowering movement. It certainly has been for many people living with HIV, and it's going to, we hope, help bring this disease out of the shadows some more. The Lancet this summer or last year, around World AIDS Day, had a piece on this in U equals U. It's very optimistic. You can see I've just highlighted in red how positive they are about this, but they are talking by 2020 of the complete elimination of the entirely unfair and outdated stigma still faced by many people living with HIV today. If we actually could address HIV stigma by 2020, It would be a beautiful thing. How many people think that's going to happen? Well, anyway, we need to make some progress. But one of the important aspects of stigma, of course, is the enacted stigma that is coming from the legal sector. And it's very hard to say to people that they should get tested, they should learn their status, they should be open, they should disclose to their sex partners when that is still criminalized in so many places and people face legal sanction. And I was a part of this expert panel. We presented this summer in Amsterdam with Prevention Justice Alliance and others, where we really reviewed the legal standards that are out there and how incredibly out of date they are with the science. It is really striking. And so this is a call, it's an expert review of the data, and then a call for decriminalization and legal and policy reform. But it is remarkable how many people are still being prosecuted. While we were working on this, there was a case that came forward in Malawi of a woman being prosecuted for breastfeeding transmission. Without a transmission, by the way, but breastfeeding exposure. So it's still an issue. And then I think maybe the last thing to say is just that there is a really innovative movement underway. I've certainly been a part of seeing this happen and unfold in Thailand, where more and more services are being led and delivered by key populations themselves and in settings that are really congruent with what people want. So we have, a sex worker clinic in Bangkok that is providing PrEP to sex workers. And with the advances in technology, we have things like point-of-care creatinine. Takes 20 seconds. Now it becomes incredibly easy. You can do same-day PrEP initiation in a community clinic space. And that can be really owned and run by stigmatized populations, by sex workers, by transgender women. And I think this is, to me, is an example of one of the innovative programmatic ways that we may really start to not so much reduce the stigma, but bypass it and let people get the services they need. So I'm optimistic that we have a lot of ways forward. Very much looking forward to being with you for the part of the day that I can join you for. And I just want to close by thanking my many colleagues, a number of whom are also collaborators on Project SOAR. Thanks for your attention.
Take the big step up. So thank you so much, Chris, for helping us set the stage today and highlighting some of the issues that we're going to be focusing on. And now what I'd like to do is introduce to you our 4 speakers who are working on gendered stigma. They will share with you their activities, their research, their insights that can help provide directions for tackling stigma and HIV, some of which Chris already highlighted. Let me start. I'm just going to introduce the 4 of them now so that we can then go back to back with the presentations. And we're going to be holding questions to the question and answer period toward the end of our session today. Let me first introduce Dr. Silvia Adebayo. Sylvia is a physician and director of the Population Council's office in Nigeria. Among many other activities, Sylvia and her team implement a large-scale initiative in Nigeria that provides sensitive HIV services to at-risk men, and particularly men who have sex with men. Next, I will introduce Barbara Friedland. Barbara is a social scientist with the Population Council's HIV and AIDS program and has been involved with both clinical and behavioral research. Barbara led the team on the Project SOAR activity to update and test the People Living with HIV Stigma Index. After Barbara, we're going to hear from Kelly Curran. Kelly is the Senior Director for HIV, Malaria, and Infectious Diseases at JPIGO, which is an affiliate of Johns Hopkins University. Amongst many roles, she serves on the technical advisory group of the Sauti project in Tanzania, which you'll hear more about. This project brings HIV services and prevention activities, including those focused on stigma reduction, to key populations and their children. And then finally, I would like to introduce Dr. Eileen Yam. Eileen is a social scientist and deputy director of Project SOAR. She will describe council-led research around the Sauti project in Tanzania that addresses the reproductive health needs of women living with HIV. So I turn now to our first presenter, Dr. Adebayo.
Good morning, everyone. It's a pleasure to be here to speak on a very important topic, addressing gendered stigma in Nigeria. Okay, slide. Okay. All right. Well, you've heard a bit about Nigeria. Nigeria happens to be a country with the second largest HIV prevalence and HIV burden globally. It is believed to have a concentrated epidemic, concentrated amongst key populations, particularly men who have sex with men, among whom HIV prevalence is several folds higher than their counterparts, male populations. As you've also heard, men who have sex with men are highly stigmatized and criminalized in Nigeria. And the legal environment does not also help the situation, where on the one hand, we have several laws and policies and programs to address HIV reduction risks. However, on the other hand, you have policies and programs that do the exact opposite. For example, in 2014, the government of Nigeria passed a new law, the same-sex marriage prohibition law. Now, what this has done is, you can imagine passing this law in an already homophobic and hostile environment. Now, the effect of this is it further worsens the situation in Nigeria, particularly for key populations and men who have sex with men, in reducing their chances of accessing care and for healthcare providers to provide the needed interventions that are necessary. Now, this slide, which is taken from one of our studies in Nigeria, a cohort study with other partners, shows how the immediate effect of the same-sex marriage prohibition law, after it was passed, and the effect on, stigma, exacerbating stigma, and uptake of healthcare services. Now, strategies to reach MSM and other key populations less likely to engage in uptaking HIV services actually worsened in environments that are hostile and reduce, uptake eventually. Among MSM, even within the subpopulation of MSM in Nigeria, there are certain subgroups, particularly men who sell sex, who are at greater risk of exposure to stigma. So that's an example of the gendered stigmatization within the MSM population. As you can see, unfortunately, I can't see, the slides closely from here, but you can see that the HIV stigma is actually higher among male sex workers than the non-male sex workers. So what this tells us too is that there is a need for us to recognize that within subpopulations of MSM, number one, it's a heterogeneous group and not homogeneous. So there's a need for us to tailor the needs of each of the subpopulations to address their peculiar needs. Now, against this backdrop, the Council over the last decade has worked in addressing stigma among MSM and other key populations. I keep talking about MSM because they're at the center of it all, but then we also have intervened providing services for other key populations. Starting from conducting the first study among MSM in Nigeria in 2006, which revealed the very high HIV prevalence in this population and the high vulnerabilities to HIV and other STIs. What we did was to establish the first largest HIV prevention and treatment intervention, creating demand for the services by training and capacitating key opinion leaders. Now, key opinion leaders are peer educators within the MSM population, representing different subpopulations to capacitate them to identify, to start with, the high-risk peers, and provide counseling and testing, HIV testing, and linking them to care. So we ran that for 5 years with funding received from CDC in 3 states in Nigeria. Beyond that, we collected, of course, monitoring and evaluation data, which we used to influence, the work and our programming. And in 2013, with funding received from the Department of Defense, we established the community-based health center, which provided comprehensive HIV prevention, treatment care, and treatment services targeted at MSM and other key populations and their male and female sexual partners. Again, building on all the lessons learned over the years. In 2016, with funding received from the Elton John AIDS Foundation, we expanded, the scope of our work, taking the services closer to communities by training focal persons within public and private clinics and facilities, so that they could provide HIV key population-friendly services targeted at key populations and their male and female sex partners. So going beyond the hub, the community health center as a hub, to the spokes, as a hub and spoke model. And this has helped in expanding our services to start with, and then to also normalize, the services, which is one way of, overcoming the HIV stigma in this population. We've also adapted several other interventions. You've heard about the oral HIV self-testing, which was one of the, and I'll talk a little more about that. Layered on the services we provide are also ongoing research that we have conducted to understand the needs of this population, measure the HIV prevalence and incidence, and so on. Now, this is just an example of the hub and spoke model that I tried to explain. With funding received from the Elton John, we've expanded our work, providing community ART and PrEP, closer again to where, people, men who have sex with men who would normally and ordinarily not access care, no matter what we do, but taking the services closer to them. I'll come back to this slide. But just to say, this is just to show the HIV self-testing, which we rolled out first, with this feasibility and acceptability and linkage to care study, using key opinion leaders as distribution channels of the HIV self-testing. And within a month, we were able to recruit 319 MSM through the key opinion leaders, and they distributed HIV self-tests to their peers. And out of 251 MSM who used the HIV self-testing, 14 of them turned out to be HIV positive. Just to also mention that most of them were first testers. 14 of them were HIV positive, and all were validated as HIV positive. And out of all those who were positive, all were linked to treatment, and all, linked to the full treatment, which shows that HIV self-testing is actually a viable and potential innovative intervention to reach, at-risk populations who would normally not access care. Going back to this slide, along the way, we have actually learned a lot of lessons. First, to achieve the 1990 strategy, where we've been able to test quite a number, and this is just from the Elton John AIDS Foundation project. Over 11,000 men were tested, out of which all those that were HIV positive were linked to treatment either at the spokes or at the hub, and 90% of them virally suppressed. We have learned a lot of lessons as we've gone along. First, to show that without the Community Advisory Board, which is made up of the government as partners and law enforcement agents and so on, who actually, particularly the law enforcement agents, who encourage, sometimes the hostile environment, bringing them on board and having them to play a role in the HIV intervention. This has helped us as a risk mitigation strategy. Key opinion leaders have turned out to be very important as a group within the MSM and key population subpopulations to reach their peers and provide HIV counseling and treatment, which is a way of task shifting and providing, identifying them as frontline healthcare providers. And then they're also very useful in retaining them in care, retaining their peers in care. We've also learned quite a lot too about the use of social media and social technologies as recruitment strategies to retain their peers in care and also for referral. With all this, there's still a lot of work to be done. We have done a lot, but there's still several gaps to be filled, and but we need a lot of research to understand the needs, peculiar needs of subpopulations of HIV and the gendered exposure to stigma and what effects it may have for programming in this population. So please stay tuned for further results as some of our work will be analyzed and published. At this point, I'd like to just say thank you and to acknowledge my all the funders, USAID, the Department of Defense, Elton John AIDS Foundation, NIH, and the Population Council, my colleagues, and other colleagues from the Johns Hopkins and University of Maryland and the Trust Study. I would like to, at this point, just say thank you for listening, and I would like to turn the microphone over to Barbara. Thank you.
Good morning, good afternoon, good evening, everyone. I'm very pleased to present some results from the updated People Living with HIV Stigma Index. Before I go on to the presentation, though, first I would like to thank my colleagues Ann Goddard and Tracy McClare, who worked very closely with me on this presentation. I'm going to just give you very brief background on the Stigma Index itself, and then we'll go into some of the data that we have gotten so far. So for those who may not know, the People Living with HIV Stigma Index is a survey that was developed to quantify stigma and discrimination experienced by people living with HIV. The results from the People Living with HIV Stigma Index are used for advocacy, policy reform, and service delivery. It was developed by the Global Network of People Living with HIV, the International Community of Women Living with HIV, the International Planned Parenthood Federation, and UNAIDS in 2008. And since 2008, over 100,000 people living with HIV have been interviewed. Over 2,000 people living with HIV have been trained as interviewers, and it's been implemented in more than 90 countries. So, in the 10 years between 2008 and 2018, there have been many shifts in the HIV epidemic, and in particular, as Chris mentioned before, test and treat. And one of the impetuses for updating the Stigma Index was due to the evolution of the epidemic in this past 10 years. So the Stigma Index partners thought that it was time to update the Stigma Index, and working together with the Stigma Index partners, the Population Council's Project SOAR led this update process, which was supported by PEPFAR USAID. In addition to the small official group of people working on this update, there was extensive consultation with various networks of people living with HIV globally, and excuse me, key opinion leaders in different countries, people who had experience implementing the Stigma Index in the past, and funding entities. The new Stigma Index was released last year at the end of 2017, and it's already been implemented in half a dozen countries, and the Population Council is involved in 2 projects to roll out in the Dominican Republic and in Cambodia, where we're just about to start in those 2 countries. So the main features of the Stigma Index update, which were based on all the input that we got during this consultative process, one of the main things was to better measure intersecting stigmas. So what kind of stigma is related to HIV status, and what kind of stigma is related to people's identities or behaviors. We updated the healthcare section in particular to reflect that there's now treatment and viral load testing and all of the much more nuanced look at healthcare in the day and age where that is now the recommendation is treatment for all. One of the things that the people consulting with us said was, well, we think that there's probably higher levels of stigma in general healthcare settings versus the HIV-specific healthcare settings. So we created different questions to measure stigma in healthcare general and also specific to HIV to see if that was in case the fact. We added mental health and internalized stigma questions, and we also developed a new resilience scale. This was spearheaded by my colleague Ann Goddard, and this was again in response to the community that said, well, we shouldn't be only measuring stigma, we should also be measuring resilience because we can learn from the people who are resilient. So with this updated tool, a draft of the updated tool, a very good draft of the updated tool, but still a draft, we fielded this updated Stigma Index questionnaire in 3 African countries. Our target was 400 people per country in Senegal, Cameroon, and Uganda. Each of these implementations was different, which kind of reflects how it differs from country to country and setting to setting when people are actually implementing the Stigma Index. So the Population Council worked together with the National Organization of People Living with HIV in Uganda to implement it there. And Steph Baral and his team at Hopkins provided technical assistance to organizations in Cameroon and Senegal who implemented it in those 2 countries. And in each one was slightly different, but basically we all used the same tool. It was implemented on tablet computers or on mobile phones. And the initial Stigma Index was on paper in most cases, and the interviewers would sit side by side with the person they're interviewing. And so this was still the same way that it was implemented on a tablet computer or a phone. So who did we interview? We did reach at least 400 people in each of the countries. People were a little bit older than we might have expected. On average, they were 36, but ranged from 18 to 81. And to be clear that to be eligible for the Stigma Index and in this study, people had to be 18 and older. People knew their status for about 6.5 years on average. The majority of the participants were female. And I also want to note that in using the word female and male, that is the language that's used in the Stigma Index. So I know there's a lot of discussion about women and men versus male versus female. So I'm reporting the results based on how it's framed in the Stigma Index. We also made a concerted effort to recruit people from key population groups because we wanted to be sure that the questions that we were including were responsive to a wide range of populations. Interestingly, almost everyone who responded to the Stigma Index was on treatment. But in terms of viral suppression, that was lower, 61% of people in Cameroon and Senegal, and 42% in Uganda. So the next set of slides that I'm going to show you are about experienced stigma and internalized stigma, which we have just started to look at based on gender subgroups. And in terms of experience of the stigma, what we're talking about are things like family members made discriminatory remarks, excluded from social activities, verbally harassed, physically harassed. Those are the types of questions that people are being asked. And in this slide, you can see this is the percentage of people who experienced at least one of these types of stigma in the past 12 months. And this is broken down by men who have sex with men and men who do not identify as having sex with men. And as you can see, that there's considerable variation both within and across countries. Similarly, the same set of questions, and these are for the women who you can see differences between women who are sex workers and women who do not sell sex. Next, these are internalized stigma. This is based on Seth Kalikman's 6-point scale, where 0 is no internalized stigma and 6 is high. And internalized stigma are things like being HIV positive makes me feel dirty. So you can see here again, pretty high levels of internalized stigma among men, with differences by subgroup, as well as among women, with differences by subgroup. On the other hand, our new resilience scale did show substantial resilience. The questions are a set of items where people are asked, did you feel your HIV status made you more positively able to deal with stress, not affect your ability to deal with stress, or negatively affected your ability to deal with stress. And we did see, again, a variation by population and by country, and in most cases it went the way that you would think in terms of gender, where men who have sex with men and female sex workers experienced lower resilience than their counterparts who were not sex workers or men who have sex with men. And we're just really starting to unpack this and try to figure out what other things are associated with resilience, because as I said before, if we can figure out how people are resilient, hopefully we can build that into interventions. Finally, we looked at how gender affects HIV care. So HIV testing delays, the percentage of people, regardless of country, gender, anything, who reported that they delayed getting tested because of stigma was just extremely high in all of the countries. But this was particularly pronounced among female sex workers, with significant differences between sex workers and non-sex workers in Senegal and Uganda. The second two bullets are about people's experiences of stigma in HIV care settings. So this is where people thought this is going to be better. It actually turned out that the treatment people received in HIV care settings and non-HIV care settings was not that different. And shockingly, in Uganda, in HIV care settings, 13% of women and 2% of men were advised not to have a child because of their HIV status. And then the experience of stigma among MSM, these rates that I'm showing here, these are similar to the types of things that Chris was showing on his slide, but that was in the community, and this is in HIV care settings. 42% of men who have sex with men experience verbal abuse in Cameroon, compared to 15% of men who don't identify as MSM. So this is in the place where they go for HIV care. In the other series of questions that we asked specific to identity that wasn't necessarily related to HIV, you can also see that there's extraordinarily high levels of stigma and discrimination among men who have sex with men, verbal harassment, blackmail, and physical harassment. Similarly, transgender women in all three countries also experience very high levels of stigma and discrimination. So obviously, stigma is still a huge issue. We see that. It's the case in all three countries. We also see that gender-related stigma impedes health seeking. And it's really important for us to be able to unpack these intersections of gender and stigma to help tailor interventions. And we think that this new version of the Stigma Index is very helpful in being able to look at stigma and identity and gender and both internal and external stigma in a more nuanced way that will help us to better design interventions that can meet the needs of people living with HIV. Thank you. Oops. Sorry, we have a lot of people to acknowledge, so I'll leave that there while I introduce Kelly Curran, who's going to speak next.
Thank you so much. It's really an honor to be here and to give a bit of a perspective from the implementer side of things. I think that the order of these presentations has been really nice in terms of setting up. Chris did a great job setting the stage and then having access to some of the research findings. And my task now is to talk a bit about how does stigma and gendered stigma and stigma particularly faced by key populations express itself in the context of a large HIV service delivery program that's PEPFAR funded. And so I'm actually here presenting on behalf of my colleague, Dr. Albert Komba, who is the chief of party for this project. He was unable to get away from pressing donor meetings and project needs. I'm sure everyone who works with PEPFAR can understand as we head into the final days of Q1. But he sends his regards, and I want to thank both him and his team member, Esther Majani, who leads our gender and dreams work in Tanzania, for helping me pull these slides together. Again, just to say, Sauti is funded by PEPFAR through USAID. It also has USAID population funding, which I think is a really wonderful aspect of this project and something I'll speak about in a moment, but it has enabled us to do some things that we can't always do in PEPFAR-funded programs. And we also have funding from the Elton John AIDS Foundation to support activities with MSM and female sex workers. Just to say, the Sauti project has also been a platform on which a number of Project SOAR activities have been implemented, as well as some Bill and Melinda Gates Foundation-funded studies. So just to go through the Tanzanian epidemic sort of briefly, it's a big epidemic. It's a big country and a big epidemic. 1.4 million people are living with HIV. Prevalence is 5% in the general population, with very stark differences by sex. 6.5% of adult women are living with HIV versus just 3.5% of adult men. And in terms of incidence, there's even a bigger difference, where the overall incidence rate, and these are data from the recently conducted FIA, overall incidence is just under 0.3%, but it's more than twice as high in women as in men, as you'll see. And so, if anything, I think we can see right now in Tanzania that the gender sex differences in the epidemiology are widening, actually, at this point in the epidemic. These data are also from the FIA, the Progress to 90-90-90 by Sex, and I was really glad that Chris made the point that actually gender and gendered stigma affects men as well as women in terms of accessing care. It just affects access to care in different ways. With men, I think a combination of male norms of masculinity, as well as just some barriers to seeking care during the traditional working hours of our clinics, mean that men are less likely than women to have been diagnosed, to be on treatment, and to be virally suppressed. There is some discussion about the first 90 data from the Tanzania FIA, but regardless of whether this is maybe a slight underestimate of people who know their status, I don't think anyone who works in the Tanzanian HIV response would argue with the fact that many Tanzanians, and particularly many Tanzanian men who who are living with HIV remain undiagnosed. So second and third 90 are looking fairly good for the general population. Most people who know their status in Tanzania are on treatment, and most people who are on treatment are virally suppressed. But the epidemic is very different amongst key populations. A reminder that the prevalence in the general population is 5%, but it is dramatically higher in key populations. 25% for 26, 25, and 36%. I can't see these slides very well. For female sex workers, men who have sex with men, and people who inject drugs. Our program works just with the two populations, the first two, female sex workers and men who have sex with men. Our colleagues at ICAP with CDC funding are serving people who inject drugs in Tanzania. So again, very disproportionate impact on these populations. And unfortunately, even though these populations are much more likely to be living with HIV than their general population counterparts, the ability to be linked to care is a real challenge. And so these are data, again, from 2016, which was a period where things started to become challenging, even more challenging for these populations in Tanzania. But you'll see that in many cases, less than half of people, or just about half of people who are diagnosed with HIV, have been able to successfully link to care. And if you remember, the overall Cascade for Tanzania shows that the majority of people who are diagnosed are actually on treatment and virally suppressed. That is not the case for key populations. Key populations have not been able to successfully access treatment at the same rates in Tanzania, and I'm sure that is true in many of the places where we work. So a bit about Sauti. Again, it's a very large project. It provides both combination prevention services, so biomedical, behavioral, and structural interventions, along with family planning services, to a number of key and vulnerable populations. As I mentioned, men who have sex with men and sex workers. We have also, over the last 18 months or so, been making a very concerted effort to reach the children of female sex workers, who are a population that have been underserved by traditional pediatric programs. And then we also do a great deal of work to reach male partners of both sex workers and adolescent girls and young women, and then adolescent girls and young women themselves. Sauti is one of the DREAMS implementing partners in Tanzania. To give a kind of concept of the scope of this project, which is being implemented in 14 regions. So all the dark blue are the regions where we're implementing. And again, Tanzania is a very large place. Our testing target for the PEPFAR folks in the room, our total tested target for the year that ended 30 September was 1.14 million. And we were aiming to diagnose just under 37,000 people with new infections. So again, it's just a large program. And just to talk about specifically, and I know that Eileen will be getting into this in more detail, but some of the ways that gendered stigma in particular affects female sex workers living with HIV. And I think this is a population that is extremely vulnerable. They are HIV positive. They are selling sex. As we saw, about a quarter of them are living with the virus, but very few, relatively few, have been successfully linked to care. And some of the things that come up in community consultations, actually, housing is a huge. Safe housing is a huge issue that comes up over and over, particularly for women living in Dar es Salaam. There have been efforts to bulldoze some of the brothels, and housing is a big issue that comes up. I think the treatment at government health facilities is oftentimes stigmatizing, and I think this is very consistent with the limited ability to successfully link to care. There are also something I'd like to talk about, and I wish we had more time, is index case approaches and how this kind of plays out for female sex workers living with HIV. We obviously believe in the public health promise of partner notification and index case approaches for testing, but how the reality on the ground, I think, for HIV positive sex workers is, particularly if they are identified as a sex worker when they're at a care and treatment site, is they're often kind of relentlessly pressured to disclose the names of their sexual partners. And it's just, I think we need to find a balance between the kind of public health needs and not create a barrier for this very vulnerable population to seek care. A number of the women that we work with over the past couple years have been arrested at different periods, and the positive women are very rarely, almost never actually, able to access treatment while they are in police custody. This is a big challenge, and obviously treatment interruptions pose a huge issue. And then finally, Eileen is going to talk much more about safe conception practices amongst female sex workers, and that is a challenge. So just to say that I won't go through all of these slides in the interest of time, but that's a bit about the context that this project is being implemented in, and to say that we really tried to take all of this into account as much as possible when designing this program. And so how in community consultations, and I think I must say that USAID and PEPFAR were very kind of forward thinking when this project was designed in 2014 and 2015 in acknowledging the necessity of having a community-based delivery platform so that these services could be offered in locations that were accessible, both geographically accessible, physically accessible, and kind of culturally accessible to the populations. And so this photo represents a tent that is pitched up outside a brothel where testing and family planning services are offered. So we're actually even able to offer family planning methods as well as HIV testing services in the tents, including implants. And so I think the program is able to screen providers for KP friendliness and adolescent friendliness. And so we have an ability, I think, to control a bit more the friendliness of the providers than you might in a government healthcare setting. And then finally, just to say that I think having family planning services and economic strengthening services together with biomedical HIV services is really critical. It enables especially adolescent girls and sex workers to come into services. Sometimes the family planning is the hook, for example, for the adolescent girls. And we're very fortunate to be able to deliver services in community settings. In Tanzania, oral PrEP is actually being implemented under an IRB protocol, as well as community ART, and this is work that we've done in partnership with our Pop Council colleagues at Project SOAR, but we have been able to deliver both community ART and oral PrEP in brothels, bringing nurses into brothels to deliver these services. And I think our hypothesis is that hopefully initiation and continuation rates will be higher if we make it a little bit easier for folks to access services and limit some of the barriers that they experience in the government health setting. Just as I mentioned, I think, there are gender issues related to index case testing and partner notification. And I just want to draw your attention, I think these slides will be shared later, but a paper that we published about the gendered aspects of partner notification services in Tanzania, that in general, men had a much easier time referring their female partners than women did. And I think fear of abandonment, marital dissolution, but also in this paper, we really saw a lot of single women actually expressing that it just was simply inappropriate for them to reach out to male partners who may be married now to other women or may have always been married to other women during their study, that it was just completely inappropriate to interfere with other people's marital relationships. So I think this deserves a further discussion that we don't have time for today. Finally, and just to kind of wrap up, gender-based violence screening has been integrated into this program for some time, but it's been a real challenge. I'll just be very honest. You'll see that, this cascade is kind of a miserable cascade, if you will, that Sauti has reached more than 2.5 million people, 1.7 million of whom have been screened for gender-based violence, but only a very tiny minority of clients have screened positive to the questions, and a much smaller percentage even of those folks have been supported through the reporting process. And I think there's a couple of reasons there. Just the practical reality of integrating gender-based violence screening into biomedical services, where there is a focus on clinical services. It's difficult for the providers to have enough time to really elicit a conversation that is needed with the clients. As a result of this, we are moving towards moving a lot of the gender-based violence screening out of the clinical services and into the economic strengthening activities, where we believe that there will be more time to facilitate these discussions. So finally, just to say, in conclusion, I think gender differences and stigma affect many populations in accessing services, and this expresses itself in different ways for different populations. I will say that integrating some of these services is possible, but it's difficult. And I would encourage everyone to be flexible and to look at their data to see what it's telling them, whether or not integration, for example, into clinical services like HIV testing is the right way to go. Thank you very much. Asanteni sana.
Thank you, and thank you to my co-presenters for queuing me up so well. What I would like to do is, following up on this foundation that they laid, and I apologize for my voice, I'm fighting a cold, I'd like to lend some conceptual clarity to illustrating a very specific context in which women living with HIV experience a very gendered type of stigma, and actually a convergence of various gendered stigmas. So I come at this from a family planning background. This is a model from a commentary we published last year. It was called Family Planning for HIV-Positive Girls and Young Women, and it depicts the different life transitions, family planning-related needs that these adolescent girls will have as they age into adulthood and beyond. And you've already heard from our other speakers about the need for addressing contraceptive need. And I think in the context of a convening on gendered stigma, I really want to focus on this piece here at the bottom, the healthy pregnancy and baby, I think that's what that says, which really is given short shrift in this conversation about family planning and in the HIV response writ large. So thanks to the biomedical advances you've already heard about, the U equals U era we're in, women living with HIV can conceive more safely. So of the nearly 37 million men and women living with HIV right now, about half, 19 million, want a child this year. And the takeaway now, in the era that we're living in and where the epidemic is now, is that they can, and their babies can be HIV-free. And when people hear HIV-free baby, they think I'm about to launch into talking about PMTCT. And this is an intervention that typically kicks in when a woman is already pregnant. She is diagnosed in antenatal care. She knows she's living with HIV. She's on treatment and reduces the risk of vertical transmission. But really, this conversation needs to happen further upstream. So safer conception refers to intervening when a woman who is living with HIV is contemplating pregnancy. She's not yet pregnant. She wants to get pregnant, wants to reduce the risk of horizontal transmission to a seronegative partner. And there are many behavioral and biomedical strategies for her to do that, ranging from timing condomless sex to her most fertile days, upwards to sperm washing. So the takeaway here is we have the biomedical and the behavioral strategies to achieve this end. But what happens from the moment a woman living with HIV contemplates pregnancy? Here she's going to run into this convergence of stigmas that are very gendered. I'm going to try to animate the slide without really seeing it. So she'll be told she should not be having sex in the first place. Her partner may leave her if she discloses her status. That speaks to the internal and anticipated stigma. Providers will disapprove. And if she does become a mother, she's a bad mother. And the cruel contradiction here is that in many places on the planet, it's incredibly stigmatizing not to be a mother. And then on top of it, just to cue you up for the study findings that I'm going to present briefly, imagine on top of this all she sells sex. So you can see this is an array of gendered stigmas that she will run into. So Kelly alluded to a Project SOAR study that we conducted in Southeast Service Delivery sites in Dar es Salaam. And we were interested in doing essentially a service provision assessment, a series of client exit interviews, observations of provider consultations, qualitative interviews with the women and with providers to learn a little bit more about these women's desire for children and what they thought about how those desires were being accommodated. So 55% of the 300 women we spoke to who were living with HIV and who sell sex, they wanted to get pregnant someday. So that's not that different from studies around the world with women living with HIV, whether they sell sex or not. And 28% wanted them within 2 years, largely with their current husbands or boyfriends. And I'd be remiss if I didn't emphasize they also had very high unmet need for contraception. About 29% did not want to get pregnant within the next 2 years, but were not using a modern method. And they really, really loved Sauti's services. They thought the care was incredibly respectful. 100% said the provider treated them respectfully. But I do want to emphasize that 31% really wanted to hear more about family planning. And specifically, 80% were very interested in learning about how HIV-positive women can get pregnant more safely. So in closing, I hope the takeaway here is that when we are talking about women living with HIV and family planning, that conversation really needs to be expanded to include not just contraceptive need as well as their need for safer conception. And gender matters in all of this. And I think that, Dr. Byra quoted Dr. Redfield about how stigma is the enemy of public health. But I really feel, as I've been listening to all these presentations, that in the context of U equals U, when we're thinking about normalization as the enemy of stigma. When we're talking about normalizing leading a full and healthy life as a person living with HIV, we have to explicitly acknowledge that normalization also has to include normalization of motherhood for women living with HIV. Thank you.
So thank you, Eileen, and all the presenters. It was just great to highlight all of those different issues, as you see, are intersecting and lead to these different facets of stigma that we need to address. I'm now going to ask our panelists to join me on the stage. And this next discussion moment will be an opportunity to reflect on some of the themes we've talked about today, as well as to share their own experiences related to addressing gendered stigma and confronting it in their own programs as well as their own lives, and how we may think about strengthening our response to stigma, and particularly gendered stigma. So first joining me on stage is Clara Banya. Clara is the national, thanks so much, Chris. Clara Banya is the national coordinator for the international community of women living with HIV and is a member of the African Community Advisory Board for Y+. Clara also offers technical advice to persons living with HIV organizations, encourages testing, combats stigma and discrimination, and speaks publicly about HIV in Malawi. We also have Dr. Janet Saul. Janet is currently the Senior Gender Advisor in the Office of the U.S. Global AIDS Coordinator and Health Diplomacy. In this position, Janet provides technical leadership to the DREAMS Partnership, amongst other activities, aimed at preventing HIV among adolescent girls and young women. She also advises senior leadership on strategic directions around primary prevention of sexual violence and HIV. We had a third panelist that we were hoping would join us from UNAIDS, Regan Hoffman, and at the last moment she was pulled away into busy UNAIDS activities. And so what I do have is a couple of reflections from her that I will kind of share when the moment is right in our discussion. So first, let me go sit with our panelists. First, I'd like to give both Clara and Janet an opportunity to share reflections based on their own experiences as well as anything they've heard here today. And then we'll get into a few questions probing further about our responses to stigma and specifically gendered stigma in the context of HIV. So, Clara, would you feel comfortable starting first?
Yes.
Thanks.
Thank you. Good morning, good afternoon, and good evening, everyone. I'll start with posing a question. HIV epidemic is evolving rapidly, and we can see it through the biomedical advances, funding shifts, and the reprioritization. But in your opinion, do our efforts tackling stigma need to adapt to keep the pace that the epidemic is taking? In my opinion, I'll say yes. Just as the epidemic is evolving, so is the stigma associated with it. Use of the interventions like HIV test kits and PrEP bring with them a wide range of exposure to stigma, especially around the one's sexuality, like key populations or lifestyle or behavior that is probably not deemed appropriate. For young women in particular, their access to PrEP, for example, is always impeded by the question by adults or peers about their risky behavior and why they need to prevent HIV, when ideally they should not be engaging in sex. Some women and girls may be coerced into testing by partners, particularly in transactional sex. Some women and also sometimes may face violence and rejection should they refuse or should they test positive for HIV. It's quite depressing to see that going into the fourth decade into the epidemic, women are still facing discrimination where they are tested HIV positive, especially with the PMTCT project. The time that I tested HIV positive in 2000, it took me 3 months to disclose my HIV status to my husband. Well, that time I was working as an HIV counselor. I tested a lot of women. And after some time, they were coming back to me to say, Clara, look, we've been chased away from our homes. And when I tested HIV positive, I was also afraid to say, okay, so if I disclose my status to my husband, he's going to chase me away. But then I had to, after testing my daughter, because I was also breastfeeding and she tested HIV positive, so I said, this is beyond me now. I have to. So I did that. But women living with HIV and girls face a lot of stigma compounded just because they are women. Issues around gender violence, which is both a cause and an effect of HIV. Generally, women are seen as vectors for baby production, and this narrative has gone on so long. Our policies and our guidelines are hinged on it. The result is women can't make decisions in regard to their bodies, particularly about what contraceptives they want to use, what prevention methods they need to prevent pregnancies, or when to access or not to access better quality, with lead adverse side effects. Now, like in most of African countries, they are rolling out DTG. And there's this whole thing about a caution that has been raised to women of childbearing age. For us women living with HIV, I think we are just being considered as baby-making machines because our ambitions, our goals, our diversities, they are not taken into account. Or what they see in us is that we are there to make babies. But I last gave birth like 11 years ago. I'm not on any permanent contraceptives. I know how my body works, and I'm not planning to get pregnant any soon. But because I fall into the childbearing age, I will not be able to access DTG, which is a better drug with better efficacy comparing to other ARVs that are available there. So really, we need to be considering all these things. But also, like in Malawi, for a woman to get contraceptives, it's a non-starter. They are not available. Later on, for you to decide to terminate the pregnancy, it's illegal. You can't do that. So these whole things, they need to be considered when we are planning our programs in addressing stigma and discrimination. Thank you.
Thanks so much. Thanks so much, Clara. Really interesting insights we'll be taking it back to. Let me turn now to Janet.
Sure, great. Thanks so much for having me, and good morning, good afternoon, and good evening, everyone. I want to reflect a little bit on what some folks have already brought up, and this relates to gendered stigma affecting adolescent girls and young women. The work that I do is primarily on DREAMS, which most of those countries are in Eastern and Southern Africa, and the issue around two issues. One around just the general stigma around adolescent sexuality, and particularly around adolescent girls' sexuality and young women. How do we know this is happening? I mean, every single country we go to, when we talk to young women, they talk about why they don't go to the clinic. And it almost invariably is because if I go to the clinic and I say I'm having sex, then what they're going to say to me is, why are you here for condoms? Why are you here for PrEP? You're not supposed to be having sex. And it may even go beyond that, to only girls who are bad, other labels, have sex if they're not married, and so therefore you need to go home and not be here for this service. I mean, we hear it over and over again. The other thing we see is when we look at some of the curricula that are being used, that language that perpetuates stigma around sexuality, and words like deviant behavior that refer to just young people having sex. Those who aren't having sex then are labeled as wholesome or pure. And so again, that message that if you are having sex, there is something very wrong with you. And so there's very little motivation then to talk to adults, to talk to parents, to talk to anyone about the fact that they may be having sex. The other piece of it is that not all of the sex that's happening with adolescent girls and young women is by choice. A lot of it is forced or coerced. And so, again, some of the language that we see around forced and coerced sex in curriculum that we review gives a message of what could the girl or young woman have done differently so that this didn't happen to her. The language is not, why should the man not have done this to the 13-year-old girl? It's what could she have done differently to either stay out of the situation or get out of the situation. So again, there's that stigma. I think, I forget who mentioned it, but the mention of, screening people for GBV and then seeing that very few admit. And then secondly, of those who do admit, very few of them seek services. Well, can you imagine seeking services for forced or coerced sex if when you were in school and it was talked about as what could you have done differently to avoid it? So those are the types of stigma that we're trying to address in DREAMS. We have a kind of what I'll call a four-pronged approach to this. Three of the things that we're doing are kind of for the here and now. How can we kind of try to change the situation right now for these adolescent girls and young women? One is, a lot of people talk about youth-friendly health services, right? So we're trying to do some of that. And that includes training of healthcare workers to be non-judgmental, to provide services that are friendly and open. But that's challenging. And in some countries when we go and we hear everybody talking about how we're doing this, we're creating youth-friendly services, and then we talk to the girls and they're like, not really. I'm still not going to go to that clinic. So we still have a lot of work to do in that regard, but that is one piece of what we're trying to do in DREAMS. Another piece is bringing the services directly to the young women so that if we have community, if we have a lot of girls, let's say, in some safe spaces, then bringing the clinical services to them. Third, taking groups of young women together to the clinic from something like a safe space. So having their mentor take the girls all at the same time, that way they have the safety of their mentor being with them, and it sort of feel kind of safety in numbers of several of them going together at the same time. And then finally, what I would say the other piece is a longer-term strategy, a strategy around changing community norms, around young people having sex. And that, so we have pieces of the DREAMS core package that are community mobilization and norms change interventions. And those are some of the things that communities are tackling, is how can we prioritize saving the lives of our girls over continuing to talk about sex in the way we've been talking about it, that sort of drives it underground. And so we have some communities that are trying to struggle with that and think about how can we talk about it and address it differently. I think I'll end with that.
Thanks so much, Janet. Wonderful reflections, both of you. And I do have comments from Regan Hoffman with me as well that I think pick up several of the themes that you've just highlighted, and thought I'd go back to just one or two of them because I'm seeing some consistent themes come out in all of our presentations and many of the points that we're raising. So Regan also, from UNAIDS, the liaison, a policy liaison to the U.S., raised the issue of sexual violence and gender-based violence and sexual abuse, violence, and trauma experienced by women with HIV both before and after their diagnosis. And I would say that that's also reflected in population councils' work over time, where we are highlighting the kind of the twin epidemics of gender-based violence and HIV. And so I think both the violence experienced by women living with HIV, and then thinking about also how that relates to HIV prevention in the DREAMS context. So Population Council is the global implementation science partner around DREAMS as well. And in some of our work in Kenya and Zambia, we were finding early on that these young women, because it's focused on young women and adolescents, as Janet was describing, were reporting huge proportions of them were reporting sexual violence. And so this is both from almost I think a quarter from their intimate partners over the last year, but also from non-intimate partners over the last year. And so they're just being exposed to so much sexual violence that is driving a lot of the HIV risk as well. And that's something that we really need to understand better and address more effectively. And I think the response in country was to say we need to redouble our efforts in this area about prevention, but also tackling the gender-based violence that experienced by women living with the HIV from one's, disclosing, et cetera. There were huge challenges. Another point that Regan raised, which I think is reflected in what's been shared today, as well as council work, is the shaming of women living with HIV who choose to get pregnant or have children. And Eileen pointed out some of those points about safer conception, but also how best to support, how best to integrate better our reproductive health services and HIV services in the lens, thinking about the lens of gender-based violence and stigma, whereby I think that there are often different camps in terms of the intervention responses, that we have a response around HIV and we have a response and stigma often, but we also have a response about reproductive health and violence, and often those are not the same programs and work, and it's important to integrate the two. Another issue that Regan highlighted that I think I'd like to turn to you next, Clara, about, which wasn't one of our original questions, but I think you're a perfect example to be able to share this, is Regan highlighted the powerful role women living with HIV are playing in combating stigma globally as well. And she highlighted that the majority of law reform to stop HIV criminalization has been led by women living with HIV. And I thought, Clara, you could talk a little bit about your experience in addressing some of these challenges and in Malawi.
I just wanted to start with ICW as journal. Like ICW has documented about in over 33 countries issues of forced and coerced sterilization, and most of the cases were filed. But these cases are taking long and they're expensive, and we don't know whether justice is going to prevail for these women. It's really disheartening, but also it's depressing. It puts our effort backwards. It demotivates us to say maybe we are not doing our work right. But recently in Malawi, after all the good policies that we have in terms of HIV prevention, but also the policy that promotes that women living with HIV, after going under PMTCT, can breastfeed their children for as long as they want, to the maximum of 24 months, which is 2 years. We saw in the end of 2016 a woman being arrested for breastfeeding her child. I don't know, because maybe she was just a woman without a voice. She was not even allowed to go back to the clinic to collect her medicine, because the time she was arrested, she was only left with 5 tablets, and she was still breastfeeding. And when we learned about it, we said, no, this is not fair. We are talking about HIV prevention through PMTCT, and yet this woman has been arrested. 1, 2. They are denying her access to treatment, but she's still breastfeeding. What are we talking about? So we mobilized ourselves. We called all the responsible stakeholders and sit on a round table and strategize how we are going to go about it. Luckily enough, Southern Africa Litigation Center hurried to our call, and they helped us to hire a lawyer so that we can make an appeal, because she was already sentenced. She was charged 9 months imprisonment. So we appealed the case, and after sitting down with the jury, educating them, but also the judicial system, they sat down, and we tried as much as possible to ask that the woman should not be disclosed because of the stigma and discrimination that surrounded that case, but also that there should be any reporters when the case was undergoing. We were granted all that. Until now, we've maintained the privacy and confidential of the name of that woman. But we learned a lot from that case. We learned a lot how the judicial system in Malawi perceived about issues to do with HIV and AIDS. We learned a lot that even healthcare workers themselves, they don't understand some of these issues. And I think it's the responsibility of the communities themselves to engage all the stakeholders to educate them. And luckily enough, Malawi was also in the process of enacting the HIV prevention bill into law. And through that case, we saw a lot. We were able to identify the contentious issues that if that bill was passed like it was, it could have affected a lot of women, because us women in Malawi, we are not financially stable. And our judicial system is collapsed, so it could have put men at an advantage. If you are a woman, you've been tested HIV positive at an antenatal clinic, you come and disclose the status to your husband, you are being blamed that you are the one who has brought HIV into the home. That means definitely you're going to be arrested by that. Yet you people, you were married before you knew your status. So we pushed to say, no, unless you remove these contentious issues that are affecting us women, we won't allow you to pass this. So we had a number of meetings with the parliamentarians until all the those issues that we felt that if it was passed like that, it's going to affect us women, were removed, and we were satisfied. And towards the end of 2017, it was passed into a law. Thank you.
Congratulations. So thank you for sharing that examples, or those examples of sort of a community response. Turning to you, Janet, more from the perspective of the donor and the programmer response, what do you think are the best ways forward at this point to try to address these issues that we're talking about, gendered stigma, and how that relates to kind of policies that you are involved with?
Right, so I think one of the ways, I mean, there's so many, right? There's so many things that we need to do. And I think one of the things that PEPFAR is trying to do is start internally. So a couple of things I feel like that we've done that help us respond better and set expectations for our programming, right? Because we are providing HIV prevention care and treatment in partnership with the governments of the countries in which we're providing PEPFAR funding. And so one of the things that we try to do is just set clear expectations about our programming. And so a couple of examples of that. One is just working with our own staff. And so about 5 years ago, we created something called the Gender and Sexual Diversity Training that all PEPFAR staff were required to take. And it, we didn't, we work in a lot of different contexts. We weren't kidding ourselves that we were going to change everybody's mind about gender and sexual, different groups, different populations and subpopulations that we work with in the different contexts. But what we did want to do was raise awareness and also make a very clear statement that there is no room for stigma and discrimination in our programming, that we serve all populations in need. And so starting with raising awareness with our staff and stating what the expectations are around programming, I think was a good step. Another example of that, I think, is in our COP guidance. This is our guidance that we put out every single year to the countries that we work with for them to do their annual planning. And in fact, just a little plug, the COP guidance for this year just went up for public comment. So if you'd like to look at it and see what we're saying about these issues and make comments, you can go to pepfar.gov and do that. But in the COP guidance last year, and it is still in the draft for this year, again, there are very clear expectations that we serve all populations. And I think that this at least sets an expectation that even though there may be challenges in the settings in which we work with regard to policies that might be in place, that the charge to our teams and to the staff who work on those teams is to try to find a way to work with those partner governments, other donors, to make sure that all are served.
Thanks, Janet. Great. So now what I'd like to do, being sensitive to the time, is I'd like to open it up to the audience, the folks in the room, to share questions or comments for our panelists or for any of the presenters that came before this panel. I'd like to take a couple of comments or questions, and then we'd go to the next round if there are any. Yes. Please introduce yourself.
Hi there. I'm Mark Lagon with Friends of the Global Fight Against AIDS, Tuberculosis, and Malaria. Thank you for your insights. In this context of stigma and gender, there are outside players, big donors, partners. I'd love your thoughts on the respective roles of PEPFAR as a big player that's bilateral in nature. UNAIDS is a traditional intergovernmental organization as a standard setter and a keeper of data in the sense of where we are. And in the middle, the public-private partnership of the Global Fund, for whom I'm an advocate, admittedly.
Thanks very much. Are there any other comments or questions at this point? Right up in the front.
Thank you. I'm Jeff Spieler, retired from USAID. Gosh, these are really great presentations, and I've got a number of comments, if I may share them, and questions. For the Stigma Index, it's really great, and the improvements in it are great. The question is, how does it lead to change? How does it lead to change? How do you implement what you find? And Kelly was involved with implementation. And you mentioned stigma and gender disparities and gender norms, and they affect areas of service. So what do we do about it? It's interesting that HIV and family planning integration have been a topic that we have been talking about for I don't know how many years, but I once led that effort at USAID. And it looks like we still have the exact same issues 15 or 20 years later. And it's interesting that what we know about commercial sex workers, and we talked a little bit about their family planning needs, but there's good research that shows that a commercial sex worker is a much better family planning user than she is an HIV prevention person. Because we know that pregnancy affects their work, but HIV does not necessarily affect their work. And so this has been known for a while, but we really have this big issue about what are we going to do with their family planning needs. And you're confronted with all the time. We know that prevention of unwanted pregnancy, as it was said, is the most important intervention to prevent maternal-to-child transmission. Yet, one of you presented how many people are HIV positive that are not using family planning. And is it because they don't have access to services, or they don't want them? And it's a combination of both. And to what extent is it the methods available to them that impacts their decision to use methods? Thank you.
Thanks, Jeff. So why don't we start with these 2 points and questions? We could start with Mark's. Who on the panel would like to address that? Janet, please.
So I think that my biggest experience in working across those lines that you talk about is with Dreams, and I think that we, with UNAIDS, Global Fund, and a public-private partnership, we have tried to work together to think about what should be in the Dreams core package at the very beginning, and some of these issues. It was interesting in developing what Dreams would look like and that Dreams core package of interventions. Initially, we started with, the things that are most closely related to preventing HIV acquisition, like most directly, most proximal. So condoms and PrEP, things like that. And as we started talking to wider and wider circles, including those partners, and I'm a social scientist by training, but I was a little bit timid about putting some of these broader things in there, like community mobilization and norms change, which are some of the things we're trying to do to address stigma. The partners were like, you have to put this in here. And so I think that that's a clear example how working in partnership with some of those organizations has affected sort of our programming moving forward. We, of course, continue to work with the Global Fund, with UNAIDS, on sharing our lessons learned from Dreams, on talking about how we can partner moving forward with what the Global Fund's rolling out for their focus on adolescent girls and young women. So I don't know if I'm answering your question, but those are just some examples of how we've worked with the groups that you mentioned to try to at least address what we're doing with adolescent girls and young women.
Thanks. And now turning to Jeff's question, I feel like there was one for Barbara around the Stigma Index, and then one for Kelly around intervention and how we're addressing it. I can hand you mine. Jessica's on her way to you.
Thanks for the question, Jeff. So the updated Stigma Index is still kind of new, so I don't know that we have a whole lot of data yet on, how it's been used, but I can say from the pilot test that we did, the Nafapano, the group in Uganda, has worked with the government to establish an anti-HIV discrimination law. I don't know what the status of the law is right now, but that's something that came directly out of the work in Uganda. In the past, in Ukraine, results of the Stigma Index led to the development of Project Respect, which was training healthcare providers because they found that there was a lot of stigma and discrimination in the healthcare setting, and so that was a training and curriculum that came out of the Stigma Index. So it's an excellent question, and I think we'll have to see how we can be developing even more targeted interventions based on the more nuanced data that are coming out.
When you have laws, how do they work their way down to implement?
Right. Thanks, Jeff. Thanks so much for your questions. And I think, I think there's like a long game and a short game, and we have to play them at the same time. And in terms of, I will say, in terms of the short game, and the short game is important because we have fast-track targets that we need to meet by 2020. We have a huge youth bulge. We have to rapidly bring down incidence if the epidemic response is going to be sustainable. And so when I say a short game, I don't mean it's not disparaging in any way. They're both equally important. But I think in the short term, for implementation, the first step is just to acknowledge the way that these issues affect access to and use of services. And I think Sauti is an example of that, to say, we are not there right now in Tanzania where we can offer services in the public sector that will be widely used by the most vulnerable populations. And so in the short term, the solution is to offer services that will be used in places and at times where they will be used. To give another example, I think for men, and there's increasing recognition that men have quite a number of barriers to use of healthcare services, particularly traditional clinic-based services. And I think the short-term solution is to develop services which are friendly to men, whether that means male-only clinics staffed by primarily male providers with different hours. We have had quite a lot of success actually in Lesotho with a clinic called Hotla, which is staffed by male nurses and which is a male space where we are able to meet the HIV and tuberculosis needs of a very underserved population, which is adult men in Lesotho. I think the longer game is to be working at the same time to address those gender norms which prevent men from accessing health services in a timely way. But while that effort is underway, which is going to be by necessity a longer-term effort, we have to take steps immediately to meet the needs of the populations. So that would be my answer to that first question. Around family planning and HIV integration, when I saw you here today, and this is a long story that some of us have been involved with for around 20 years, and I think we still have a long way to go. If I may respectfully say that I do think that the donors have a great role to play here. As I mentioned, Sauti, I think, was very visionary, and USAID Tanzania had a great vision, which was to provide population funding and HIV funding together for these services, and it has enabled us to do things that we oftentimes are not able to do in programs which are purely PEPFAR funded. Eileen's presentation did suggest that that the family planning content is probably getting a bit of a short shrift. I will acknowledge that. I think, the funding, the resources are different. The HIV funding is quite a bit bigger, and the nature of PEPFAR being target-driven means that sometimes more effort is placed on the HIV outcomes than on the family planning. But I think we have seen that when you do offer those services, you are able to meet both of those needs. Our experience in Tanzania may be a little different than in some other settings. We actually find a lot of barriers to the use of family planning among among sex workers, whether they're HIV positive or HIV negative. We actually have a paper that's been submitted and we're waiting to hear back on. But I think there are many barriers. I think I would say that starting from the perspective that it isn't an immediate assumption that all sex workers require a long-acting method of family planning is a good place to start, to acknowledge that many sex workers may wish, whether they're positive or negative, may wish and desire pregnancy. And I think Eileen's presentation was great. Starting from everyone has the right and the need to control their fertility, and that includes becoming pregnant if we so choose. And rather than, I think, as the colleague from Malawi said, oftentimes the efforts around family planning for HIV-positive women have been more focused on trying to control their fertility rather than supporting women to make the choices that they want. So just finally, I think, I would just encourage the funders in the room to advocate as much as possible for funding integration. I think that's what allows us to do programmatic integration of these services.
Thanks, Kelly. And just to add one point to the issue around how best to take this into account with programming. One of the collaborations that's ongoing is a study around recently diagnosed sex workers and how best to take into account the stigmas that they face in accessing clinic services. And it has been based on going out to the community. So how do you reach sex workers or the community of sex workers, wherever they may be? Is it geographic? Is it different sort of networks, often through peer networks and active referrals, et cetera, so that they are more able to access services while taking into account the stigmas that they face? And I think we're going to have time for one more question, but I see also the panelists the presenters had one or two comments to make before we go to the last question. Eileen and Barbara?
Yeah, and I would add the Project SOAR study in the Saudi sites was also funded both by PRH as well as PEPFAR. And it was interesting, in our dissemination meeting on the ground in Dar es Salaam, there was practically a pointing of fingers in the final slide of okay, now what? It was like PRH representative points to HIV technical advisor, and likewise, the National AIDS Commission points to the reproductive and child health section. Our guidelines don't touch that. Do your guidelines touch that? No. Silence. So I think there's also, when you're talking about who you're trying to reach, we have blinders. You hear it's sex workers, that's an HIV thing. We don't touch that on the reproductive health side. And likewise, you hear family planning, that's a reproductive health thing. We don't touch that on the HIV side. I intentionally didn't call my presentation family planning. I think I said something like planning for motherhood because I'm trying to preempt that and avert that a tendency to have this tunnel vision. But I think that's what we saw when we tried to talk about these findings, is the collective pointing fingers across the room, and it is a big challenge. I think it is a vexing one that has gone on for certainly more than a decade.
I wanted to just follow up on Carla's point earlier, which is that she said she knows her body and she doesn't want a long-acting method of contraception. Well, this is the case for many women around the world who do not want to use hormonal contraceptives. But there's this feeling that if a woman is not on a long-acting method, she will not be adherent and she's going to get pregnant and she doesn't know how to control her own body. And that's why we have to have long-acting methods for everyone. And I think what we really need to do is to do a better job of education on how the other methods work. And this is the same thing for HIV prevention, because if you don't know how your body works and how you can get infected and how you get pregnant and all of those details, then you can't really take control of your reproductive health. So I think it's beyond just HIV and it's just kind of like a foundational education and giving people information so that they can make good choices.
Thank you. And I think I saw a comment or a question here. Are there any others? Okay, I'm going to take one up here, and that's going to. Well, why don't we put them out there and see if we can answer them really quickly. So starting right over here.
Hi, my name is Scott Geibel. I'm the director of Project SOAR with the Population Council, and I just wanted to point out I actually just got an update from GNP Plus regarding the Stigma Index 2.0 this morning, and as Barbara presented, the pilots and the updating was completed by the end of this year, and now it's being also in various stages of implementation in over 20 countries in 2018. So over 15 countries are in preparation phase, 6 countries are currently implementing, and another 2 countries have completed and are in the reporting phase. So a great indication that there's strong interest by PLHIV groups around the world, under implementation in over 10% of the world's countries in 2018 already. I'd also just like to point out that also of very much of importance in the countries where the pilots took place that Barbara presented earlier, there's initial efforts to make sure that the implementing groups and the PLHIV groups in those countries are actually conducting stakeholder workshops and presenting it at both the regional and the national levels to make sure that not only are they just collecting the data, but they're taking active steps to make sure that they maximize the efforts to influence and translate the data findings into policy change. So I just wanted to mention that. Thanks.
Thank you. And a comment or question here?
Yes, thank you. My name is Amy Rurangwa, Senior Technical Advisor for HIV with Project Concern International. I want to ask a question about the presenter who talked about index case testing. It sounds like it's giving result, like in reaching the positives, but I also heard the challenge that you are facing with the Saudi project and the opinion of the women trying to notify their partners. My question here is the challenge equally big for active partner notification versus passive partner notification? And also, do you feel like it's just a Tanzania issue for that specific population? If I hear Clara talking here, and I appreciate the courage, and I know that probably other people just like Clara out there, is there anything we can learn from her experience to kind of overcome those challenges? Thank you.
Thanks for that. Thanks for that question. I think so. The study that we conducted in Tanzania found that 62% of successfully referred partners were ultimately diagnosed with HIV. I think this study was presented at CROI, and it created a lot of buzz and helped influence WHO's decision to endorse partner notification services in the December 26 guidance that they put out, and I think may have also influenced PEPFAR to put a bit more emphasis on index case approaches. And so I very much believe that we do need to do a better job with case finding, and I think that index case approaches are critical to the way of doing that. It was interesting. In our study, we offered participants the choice of either passive or active referral. So they had the option of disclosing to their partners themselves, or to have a healthcare worker do the disclosure, the notification in an anonymous way. So to show up, either to phone call or to show up at the workplace or the home of the exposed partner and to disclose. And almost none of our participants chose that method. Everyone, I think, preferred the control of managing that message themselves. I should add that this study was conducted in Tanzania before Treat All, Tanzania was a little bit late to adopt the treat all guidance, and so treatment was still at 350. And so I think that things may be a little bit different now that we have a message that everybody would be eligible for treatment. But I think we need to address the gender disparities to support women. There were no cases of intimate partner violence in the study, and we did screen out women who reported being in violent relationships from participation. There were no marital dissolutions in the study, but there were 3 relationship breakups of unmarried couples. And so these are real issues that I think we need to address. I don't have all the answers, but I think as we're implementing, we need to keep in mind that this is index case approach sounds great on a slide and a PowerPoint of a sexual network testing, but actually implementing it in the real life with real people in the context of their relationships and their families is not so easy.
So I think that's a great last comment. I'm given the high sign in the back that I'm just not going to, we're going to really need to stop here so we can get to closing remarks. And certainly our panelists and presenters will be here to hear more questions and comments afterwards, I believe. I want to thank you both for joining me up here and sharing your experiences and the perspective of PEPFAR. I think it's been great for folks in the room and also the other presenters' responses. And I'm just going to go to a couple closing remarks. So now I have 2 mics. And I just wanted to make 1 or 2 points to bring together several themes we've heard sort of consistently from many of our presenters, many of the folks in the room asking questions and raising issues, as well as our panelists. As we've heard throughout the morning, it's clear that stigma remains a major barrier to a successful HIV response, and that we won't successfully tackle stigma unless we also tease apart the intersections of gender and stigma and tackle them both directly. So, for example, we heard how MSM in Nigeria require a sensitive and stigma-free response to access HIV service and care. We heard about women living with HIV who sell sex in Tanzania, needing a stigma-free response to their desire for safer conception. The good news is that we have validated tools at this point, like the revised People Living with Stigma Index, to elucidate how these multiple stigmas intersect for people living with HIV in key populations. And we have promising strategies and programs to reduce gendered stigma and improve HIV outcomes. However, what we don't have at this point, because we've been talking about many of these issues for many years, and what we need more of is commitment from the national to the global level to support large enough community-wide programs that directly address stigma, including gendered stigma, especially for key populations. So we have a couple of really great examples now of really these larger programs, but they're needed everywhere, sort of this widespread tackling of gender-based stigmas, and especially for key populations. There's not a lot of evidence out there of successful programs that address stigma and gender stigma for key populations. So we really need to implement them more on a wide scale and show that they can be effective. And we also don't have enough of a mandate at this point, because I've been talking about this with colleagues over many years to regularly track stigma. So we hear about the enthusiasm around the People Living with HIV Stigma Index, but trying to really track it over time and show how our programs affect stigma, or our stigma affects our program success, and that what are the potential positive outcomes when we try to tackle stigma directly. We aren't measuring that consistently across our programs and with our current funding. So I think that we really want to be tracking quality of life, mental health, other issues as it relates to stigma, internalized stigma, and to show that our programs can make a difference to change the quality of life and mental health and experiences of stigma for people living with HIV. I want to thank you. That's my main reflection, and I'd like to thank you for joining us this morning. I hope you look out for some new developments coming from the Population Council. We certainly have some materials in the back highlighting many of the points we were raising today, and we're anticipating putting together on kind of the scientific literature level a special issue of a journal highlighting many of these points and how gender and stigma intersects, from kind of a new conceptual framework around that, and some examples of how we measure it and how we can successfully address it. So that's on the scientific side. And then upcoming results from Project SOAR, we have a very systematic process of trying to engage stakeholders from our representatives of our community and audience to national and global audiences so that it's more likely that these results can be incorporated into program and policy. And we look forward to be rolling that out over the next several years. So I thank you all again for joining us.